So I'm going to hand over to Barbara now. And again, Barbara, if I can just ask you to hold the mic up, if that's okay. And I'll have our three keynote speakers, and then we will move into the world of workshops, where it's your turn. Okay,
thank you very much. Will I need that?
Yep.
Okay, straightforward, forward and back. I can cope with that. Morning, everyone, and thank you very much for the opportunity to come in and talk to you this morning. I've been tasked with giving you an overview of dementia. I've worked for Alzheimer Scotland, having had a background in nursing for some 25 years, and I still feel I'm learning, so being tasked with giving you an overview in 15 minutes feels quite daunting, but I'll do my very best. I shall lay this down. What I'm going to try and do in this very short time is give you some insight into the nature of dementia, why we consider it so important at this point in time, and a little bit about the experience which we'll build on in the workshops later on in the morning. I think important to say, first of all, that dementia has no boundaries in terms of economic boundaries, social boundaries, cultural boundaries, geographic boundaries. It exists all over the world, and it is a global concern. And it's a global concern, as Brendan suggests, because in association with our ageing populations across the world, there is a growing number of people with dementia. And therefore a growing number of people with an illness that has a very long trajectory, and therefore quite a lengthy period often of a requirement for support of various natures, because that keeps changing. And it is a terminal illness. And across the world, the pattern is slightly different. A great deal of concern lies in the moment about the fact that the greatest increase is actually in the low and middle income countries. So they're looking at something like 230% of an increase in a very short period, where there's very little infrastructure, very little in the way of support services. So there are, unique challenges in those countries. Here in Scotland, we have, as far as we're aware, and as best as we can calculate, about 90,000 people with dementia. But this is a slowly evolving condition, and there's bound always to be people who are actually developing it that aren't quite, in the statistics yet. We too are looking at a projection of numbers doubling over the next 25 years, and it is a health priority here, as it is in many, many other countries. And individual countries have developed strategies to attempt to respond to this, because there's a tremendous cost to society of a condition like this, because, as I say, of the length of time that people will experience it and the nature of it being particularly progressive and changing. We're probably talking in terms of billions in terms of the actual cost of care. What we're most interested, obviously, in Alzheimer Scotland, and I hope most of the audience today will be, though, not just the cost to society, which is not insignificant, and tells us that we have to change what we're doing, because our systems, as Brendan suggested, will crumble. If we are to cope with the numbers that are being projected. We would need to, for example, in Scotland, probably to at least double the number of inpatient beds, and that's not likely to happen. And hospital isn't the best place for people with dementia either. They tend to stay in hospital longer, probably cost about 2.5 times more than people of an equivalent age and other conditions. And as I say, I hope that in spite of all that very serious challenge that presents us, we don't lose sight of the cost to people themselves, to individuals who have dementia and their families, which is probably beyond measure. So what is it? Well, we come to think of dementia nowadays as not one particular thing. It's a syndrome. It's a collection of symptoms that can actually occur in many, many different conditions, probably at least 100, if not more. But there are more common forms of it that you've probably heard of, like Alzheimer's disease and Lewy body dementia, vascular dementia, frontotemporal dementia, but there are many, many different types. And we mean by different types that they have a different pathology, but they all have something in common, which is that they impact upon the brain. They cause initially very serious cognitive dysfunctions, and eventually, because our brain controls everything in our body, very many serious physical difficulties as well as the condition progresses. As more and more is learned, more research is undertaken about dementia, we appreciate that it appears to become more and more complex in terms of, we used to kind of pigeonhole people into they have a specific type. We're now learning that quite often mixed pathologies will exist, and people may have changes of a vascular nature and the changes we associate with Alzheimer's disease, and sometimes others in combination. Because these conditions are slowly evolving, it means that people quite often are experiencing a great many symptoms before the diagnosis is made, and that quite a lot of damage is done within the brain before the diagnosis is made. So this makes the essential nature of looking at the sort of risk areas that we know about and the possibility for prevention and getting as early diagnosis as possible really essential. And the early diagnosis also helps us to involve people with dementia themselves in the decisions about their own life and to plan for the future. And we'll hear more about that in terms of our Scottish responses within our strategy, which David will tell you about later. We understand dementia now as not cause and effect. When I first started working for Alzheimer Scotland, I remember we were in a panic about aluminium pans. I don't know if anybody remembers that. We kind of got over all of that and understand dementia nowadays much more in the way that we understand cancer. There's a whole host of potential risk factors, a multitude of these, and they include aging, which is why the majority of people are older, but by no means is it exclusive to older people. And within that 90,000 people that I mentioned in Scotland, probably about 3,200 or thereabouts will in fact be under 65. But these risk factors we have to take seriously, because it means that we have some control over our futures. If we can manage some of these risk factors, particularly the things like our diet and our exercise, it's the same old story, folks, and the things that affect our cardiovascular systems, then we could in fact influence the future picture of dementia. And it's an area probably that doesn't get enough attention at the moment. So that, as I say, there are very many types of dementia. They each have their own pathologies. That means that the actual changes within and around the cells are different in different types. Different areas of the brain may be more affected in one type than another, and it will depend on the area of the brain that's affected to some extent, the symptoms that the person will experience. But whereas in the past, I think we were fairly fixed on this very medically orientated understanding of dementia, well, what you'll experience will be directly related to what has occurred in your brain. That is the damage that's done to the brain cells and its connections. We now understand it in a much wider way, because each one of us will obviously respond to changes that take place in our own way. And we each have our own lives with, if you like, our own life story, our own life narrative. And dementia collides into this personal life narrative, and that's what creates some of the most damaging aspects in terms of people and families. That happens to be my own mum, to give you an idea, who did die of Alzheimer's disease. And it's the impact on the person themselves and their families, and how we can help everyone concerned gain more control over the changes that are taking place in their life and plan for their futures, and gain an opportunity to be, as in a situation of self-management for as long as possible and living as well as possible, that we're all aiming for. David will probably talk more about this later, but this is the kind of dementia journey that is a basis at the moment for our standards and our way of developing our workforce in terms of helping them to understand that dementia can't be pigeonholed. It does have a long trajectory, and people's needs and their experiences are very different at the start of that journey when they're beginning to realise that they're changing themselves and families are noting changes and a diagnosis is made. And over a course of maybe many years, 8, 10, 15 years, these changes are occurring. But the hope we have now is that there's not a fixed pattern of decline as we used to believe in the past, but there is hope that with the right kind of support and the right kind of developments in areas like technology, that people can be helped to live well for actually a significant number of years. And then as the dementia progresses, you know, that life will require to be supported by probably a range of different types of services, but also communities, so that people are living in their own community and more accepted as citizens in a supportive environment, an enabling environment, and have planned for an end of life and dying well as we possibly can, hopefully out with the hospital environment, which tends to create more difficulties. So what kind of difficulties are actually experienced? Well, it's hard to give you a succinct flavour of that because it's so unique to every single person. And at the heart of every experience of dementia, there's a person, there's a personality who has had experience of life, as I said earlier, and has developed relationships and coping strategies throughout their life. Those different life experiences will shape how they respond to the things that dementia brings. That person will be in different states of physical and mental health and will have a different attitude towards things compared to another person. So each response is unique, and go through just the others. The physical changes in the brain, the relationships and support mechanisms that are around people and the environment all play their part in what people actually experience in dementia. So it's a combination of all of that. So we tend to talk about dementia nowadays as a bio, psycho, social and environmental situation. And I think you can add spiritual to that as well. All of those things influence how someone experiences dementia. So you can have 3 people, for example, that have exactly the same changes in their brain. Perhaps you're having difficulty communicating, for example, but each one of you will respond quite differently, and your coping mechanisms will be different. And then if you're in an environment that doesn't help you to communicate, then you'll have a greater difficulty. Whereas if you're in an environment where people understand and take their time and there's not distracting noise, etc., you will be enabled to communicate. So the hope that I would like to give to an audience like this, looking at this scenario, is that while dementia can seem such an awesome thing, and it is to try and tackle, there is tremendous hope in this understanding that there's so much more to it than just what happens in our brains, because all of those other things are capable of being influenced, particularly the environment that people find themselves in. I think maybe the most obvious example of that would be, well, people will experience, for example, short-term memory loss. Coming into an environment like this today would probably be a bit of a headache for people with dementia. It's not particularly dementia friendly because it's not signposted very well. There are, multiple areas. There's lots of clutter about. The light isn't very good. All of those things will make it really difficult for people to manage. But as I say, probably the most obvious example is if you think about the environments we've been building for people with dementia compared to environments, say, for people with visual impairment or people with mobility difficulties. If we think about dementia as bringing a range of disabilities of a similar nature, and think about memory in that way, then think how disabled people are, perhaps in a care home with long corridors, with doors that all look the same. So we have to begin to think about an environment that can actually help people function. And where we're at now is hoping that we can get the message across that if we start to influence all of those things, then we can actually help people to function better for much longer and to live well and much more independently for longer than was ever possible in the past. Because I think we tended to, when you looked at that journey that I mentioned, I think past considerations of dementia were always, or visions were towards that very advanced state, rather than thinking about the long number of years that people might be helped to live still very engaged in their own families and communities and reciprocal relationships. So I hope we are in a hopeful period as far as dementia is concerned. We're excited about the possibilities. I think I just have a couple of minutes left, so I'll round up, go back to my mother again and give you an idea of how things can combine in terms of features to give you something, I think, to think about in workshops. So you have Davina here who has Alzheimer's disease and vascular dementia. Now that's going to give her difficulties with her memory, particularly her short-term memory. So the memory of very recent events, things that have just happened, things that she's just been told. Whereas longer laid down memories might be easier, at least for a considerable period of time. And things like what we call her implicit memory, things that she's practiced over the years, will be much easier and can still be used to support her compared to trying to introduce new things. Orientation, there may be difficulty in keeping a hold of a sense of time and place, so that places that were familiar may at times be looking to her unfamiliar, but this is likely to fluctuate. And again, I would guard against ever having a notion of a fixed idea of where someone is with dementia, because there will be good days and there'll be bad days, and some things will be helpful and other things will be disabling. She will probably struggle with trying to find some words, and as the condition progresses, this might become increasingly difficult, trying to name things, and eventually, at very, very advanced stages, some people lose the ability to talk. I should say my mother never did, but that's part, I'm sure, of the drive of personality as well. And, you know, there are lots of aspects. I mentioned quite a bit about risk, but there's been some really interesting research done in the States with a group of nuns over a long, long number of years. And these nuns have agreed that their brains can be analysed after their death. And what we know from that nun study, as it's called, if you're looking it up, is that there's lots of things that we do earlier in life that might give us some protection, even when the pathology of dementia starts. So that when they did postmortems on some of these ladies, they found that there was a vast amount of damage of pathology in some people who seemed to be functioning reasonably well when they were alive, and vice versa. So it appears that keeping in good health and keeping stimulated and active, and very importantly in touch with others, your family and your community, can be protective, not just in terms of lowering your risk to getting dementia in the first place, but being protective in terms of how your brain might respond to it and sustain more, being able to sustain more damage without affecting your function. But I digress. Increasingly, things will get more difficult for Davina in terms of being able to recognise faces and objects, and that's quite a common feature. Colour and depth perception become harder, so it can be harder to judge where things are, to realise where things are not blended. For example, if you were walking into a toilet that had a white toilet against a white floor and white walls, it would be really hard to discriminate. So contrast sensitivity, appreciating the background from particular objects can be hard. Understanding, you know, the interpretation of her brain of what she sees. Reduced tolerance for noise. Someone once said that noise for people with dementia is like stairs for someone in a wheelchair. Really intolerable to many people. And there can be some difficulty with emotional control. Brendan mentioned that many people with dementia nowadays will be older and therefore will have other conditions too, and complex situations of multiple morbidity are, I think, what we're looking at more and more in the future. And my mum happened to have very common conditions of old age in her eyes. She had macular degeneration and glaucoma and lost her sight very suddenly through a venous occlusion in one side. So you've got all of that going on, and think about, you know, the interaction that I mentioned earlier in terms of how we might respond. You can begin to think about all the different various aspects where we might help and intervene to be a support. And when this has gone up, it's rather kind of lost some of the wording at the top there. But basically, I was going to pose you a question latterly. As we're thinking about what helps, think about what matters to that person. So there's lots of very clever technology that will work brilliantly for some people, but not at all for others. And so we have to hold on to that unique pattern of the individual and not assume that anything that we're going to come up with today or at any other time is going to be right for everybody, because it is such a unique experience. So look forward to seeing more of you in the sessions and the workshops. Sorry, the last couple of pictures there are just of changes that some of our specialist nurses have made in their environments to help you see how simple a solution there can be for some things. Blending colours so that people don't disappear all the time out the fire exit from the ward. That's cut down people leaving their units, but at the same time giving a bit of contrast to help people find the toilet door. So it doesn't have to be rocket science. It can be quite simple. So details will be there if anybody would like to follow up. And I lost Joyce for a minute there, so I've kept talking, but she's back now.
Thank you very much, Barbara.